This presentation is on Chapter 32, Pediatric Voice Disorders. Of what has been reported, childhood voice disorders range from 6 to 23%, and benign vocal fold lesions are the most common. Dysphonia can cause a lower quality of life in children, and it is important that these children get the team of individuals qualified to help. There is a significant difference in an adult larynx when compared to a child's. Pediatric vocal folds are shorter, and the structure is immature and only consists of one layer of cells at birth. This becomes 2 layers between 11 months and 5 years, and 3 layers by 7 years. The vocal folds are maturing throughout childhood and are in its adult form by 12 or 13 years, with all 3 layers fully developed. The larynx in a child is also more rigid, smaller, and rests in a more superior position. The subglottis in a child is also moderately smaller, and they are more likely to be affected by inflammatory conditions like croup. The length of the vocal folds is 6 to 8 mm in both genders until the age of about 10. After 10 years old, there is a significant growth in boys. In a study done, it was found that female vocal folds after puberty were 24% longer than before puberty in comparison to male vocal folds, which was 67% longer after puberty. As a child grows, fundamental frequency of speech lowers gradually, with more of a change in boys during puberty. The Adam apple also develops during puberty due to testosterone and is associated in pitch change. This is a table that is shown in the chapter that lays out the comparison of a child's larynx to an adult's. When assessing a voice disorder, it is usually done by an SLP or phoniatrist. They can start with a physical exam because physical findings can impact laryngeal function. The GRBAS, Buffalo Voice Profile, and CAPE-V are rating scales of the voice. They are helpful. However, it is important to remember that they are subjective and can vary in different listeners. An upper airway endoscopy can be used. However, on a pediatric patient, it can be difficult. In children that are easygoing and awake, a laryngoscopy can be used to identify most laryngeal lesions. However, children between 1 and 5 might be less tolerant of this procedure. The software package can be used to take pictures. However, it gives little information that could be useful. The common disorders include vocal fold nodules, vocal fold cyst, anterior glottic web, juvenile recurrent respiratory papillomatosis, and vocal fold paralysis. Vocal fold nodules are the most common cause of dysphonia in children and affect more boys than girls. The vocal fold cyst also cause dysphonia and can be acquired or congenital. Usually, voice therapy does not help and surgery is needed. Anterior glottis web can be acquired or congenital. This can present with a high pitch or weak cry at birth.